Okay, so again, I'm just admitting new people. Welcome to everybody. First of all, I would like to thank Dr. Marta García. Is our lecturer today. She's going to talk about peri-implantitis. She's expert on that topic. She's professor in the University of Barcelona, is professor in the Master of Oral Surgery and Book of Facial Implantology also in the University in Barcelona. He's coordinating several projects about peri-implantitis. He's researched also in the Biomedical Research Institute in Belviche, also here in Barcelona. We are very proud to say that he is also helping us by coordinating several clinical studies at GMI. His PhD cum laude in medicine and transnational research. His main line of research is in peri-implantitis, in peri-implant diseases. His master in oral surgery and book of facial implantology in the University of Barcelona. She has been awarded in several international congresses, and she's practicing in a daily basis in his own oral surgery practice. Okay, so thank you again, Marta. Welcome to our seminars. She also participated in others some months ago, and I'm sure that we all enjoy her presentation. So Marta, if you want to say hello, and then we will share your screen with us.
Thank you so much, and let me to show my screen, and thank you for your time, and I wish you like that presentation. And as have already present me, I am I would like first say good morning to everyone. And my name is Marta García. First of all, I would like to thank to GMI the opportunity for do this talk regarding to peri-implant diseases. As have already introduced myself, I work a lot with patients with peri-implant disease, and peri-implantitis is my line of research. I have already published a few studies regarding to diagnosis, risk factors, and treatment of peri-implantitis. And today I would like to talk about peri-implantitis from to diagnosis to the treatment.
Let me just, I forgot to say something, please. If everyone has a question, please use the chat in this platform, and I will take all the questions. I will transmit them to Dr. Garcia. Sorry, Marta.
Yeah, thank you very much, because I could be able to see the questions in the chat during the presentation. So, and the final part of the presentation, I will happy to answer to all your questions. First of all, I would like to speak of peri-implantitis. Peri-implantitis was first described in 1965 by Levinak in France. And since then, it has been a topic of concern for scientific community. So much so that if we currently introduce the term in a medical database such as PubMed, we will find more than 4,000 citations. Peri-implant disease has been described several times by an American and European Federation of Periodontics until reaching the latest definition of consensus in a world consensus celebrated in year 2017. In that consensus, they defined the disease, and since that moment, we know that peri-implantitis and mucositis are pathological conditions associated with dental plaque that affect the tissues surrounding dental implants. While mucositis affects only the soft tissues, peri-implantitis is considered a more advanced stage of the former and involves peri-implant bone loss. In a little resume from that world consensus, in this global consensus, it was established that the diagnosis of peri-implantitis without data from previous explorations should comply in the following conditions. First of all, was to see the presence of bleeding improving. This bleeding improving should be included or accompanied with a proven death equal or greater to 6 millimeters. And finally, it's important to find bone levels equal or greater 3 millimeters apical to the most coronal part of the implant. This could be that the implant suffers bone loss. As we have seen, the diagnosis of peri-implantitis is based on clinical signs that indicated the presence of inflammation, such as bleeding on proving death, and presence of suppuration. The presence of mobility of the implant indicates implant failure. So when the presence of inflammation is confirmed, it's indicated to do a radiograph exploration and X-ray that could determine the bone level and permits to diagnose the bone loss. In that point, if we found bone loss in the radiograph, we can speak that we are with peri-implantitis. However, we must consider that several factors can influence the proven death and the presence of bleeding, such proven force, the repetition of measures, the periodontal proof thickness, and especially I will talk about the presence of prosthesis, because the prosthesis sometimes can avoid the access for the periodontal proving or can affect the direction of the periodontal proving. So our records of proving could be worse. And likewise, the available radiographical techniques have advantages and limitations. The most used due to its low radiation and low cost is periapical radiography. However, we must take into account that it does not permit us to diagnose the bone levels in buccal aspect and in palatal aspect. Regarding these topics, our team in recent publications, we can observe that the proving performed with prosthesis overestimates the actual proving depth approximately 1 millimeter. Similarly, the periapical radiography overestimates the actual bone loss observed during the surgery for treatment of peri-implantitis about 1.3 millimeters. The prevalence of the disease is very high. In cases of peri-implantitis, a recent systematic review found around 20% of patients with implants could suffer peri-implantitis. For mucositis, the numbers are higher. In this case, 50% of patients could suffer mucositis. So we must also consider that the imprecision of diagnostic tools can influence the prevalence of these diseases, and it will be even higher. Recently, an evidence-based clinical guidelines have been published for prevention and treatment of peri-implant disease. This is an important document that has a lot of information regarding the prevention of the onset of the disease and how can do the treatment of the disease based in the actual evidence of treatment and prevention. According to these clinical guidelines, peri-implantitis prevention starts before implant is placed. For primordial prevention, three-dimensional position of the implant, access to hygiene, access to monitoring for peri-implant proving must be considered. Once the implant was placed, starts the primary prevention. In primary prevention, we have peri-implant healthy tissues, but we should control risk factor for the onset of the disease. Now, those with greater evidence of risk of causing a peri-implantitis are history of periodontitis, poor oral hygiene, and not regularly attending to maintenance visits on the dentist. In these guidelines, we talk about secondary prevention. For instance, one secondary prevention will be when we do the treatment of a mucositis. As we know, mucositis is a pathological condition that only affects the soft tissue surrounding an implant and is a reversible disease with the adequate treatment. But in cases of peri-implantitis, we should do a tertiary prevention where the disease is already onset. And in these cases, a first phase of non-surgical treatment is needed and a secondary phase of surgical treatment is necessary, because in cases of peri-implantitis, we have bone loss with a deeper defects that is difficult to achieve the complete decontamination of the implant. All patients with healthy implants, patients with mucositis, and patients suffering peri-implantitis should be included in peri-implant maintenance programs. So it's important for us to diagnose early the inflammatory process. Now I will discuss the treatment once the disease have already onset, has started. As we have already said, the treatment of mucositis and peri-implantitis requires a pre-treatment phase that involves the controlling of the risk factors. After that, non-surgical phase could be effective for the treatment of the mucositis, but in cases of peri-implantitis is only the first step. With that step, we will achieve reducing the inflammation, and we will achieve changes in the soft tissues, but a secondary phase with a surgical approach will be necessary for complete stabilization of the disease. Both pathologies, also mucositis and peri-implantitis, are chronic, and they have a recurrent nature. So if that patient isn't in a maintenance program, they may suffer relapses. In cases of peri-implantitis, the objective of non-surgical treatment is to go from this to this. As I previously said, the objective of non-surgical treatment is to reduce the inflammation and achieve good conditions from the soft tissues prior to our surgical treatment. During non-surgical phase, the first step is to remove the prosthesis wherever is possible, because there are a lot of prostheses that are cemented that we can do that phase. And for the non-surgical phase, will be easier to removing the prosthesis to access to the coronal part of the implant and the implant neck. When we have already removed the prosthesis, we can analyze the components of the prosthesis, because sometimes screws suffer damage and should be changed. After all, it's interesting to clean that screws, all components, and in our case, we immerse them in antiseptic solution like chlorhexidine, for instance. In cases where the access for hygiene is difficult, we modify the contour of the prosthesis. We do that with boards for ceramic and boards for metal. And it has been shown in recent publications that it has positive effects on peri-implant health. So our ultimate goal is to achieve that. After that, next steps is to do a mechanical debridement. What it consists? Well, it's a debridement of the subgingival surface of the implant neck, and the attachment. There are different methods that can be used, although those that are most effective are the use of curettes or use of ultrasounds. After that, we can do a clinical decontamination on the surface of the implant. We use an antiseptic such as chlorhexidine, although there's no evidence that that steps improves the results of non-surgical treatment. As I previously said, non-surgical treatment have limitations in cases of peri-implantitis, because lesions are very deep and it's difficult to achieve the complete decontamination of the implant only with a curette and without a flap. So after this step, we wait about 1 month or 6 weeks for achieve the objectives of reducing inflammation, and then we planning for a surgical step, a surgical approach. For surgical planning, in cases of peri-implantitis, we rely on radiological image prior to surgery and peri-implant proving, but unfortunately, periapical radiographs cannot predict the type of defect. They do some information regarding interproximal walls, but we don't know what happened in buccal wall, on palatal or lingual wall. When we do the surgery, we must expect an advanced defect that will have previous diagnosed with the radiograph. So during the surgery, in these cases, sometimes our plan is changed and we have to do intrasurgery decisions. So some approaches, it starts as regenerative approaches. And during the surgery, we found worse defects and finally are resective approaches. In our accuracy study of periapical radiographs, we observed that peri-implant defects are circumferential, but patterns of bone loss are different. In the free surface, in buccal plate and in lingual plate, the defects, the peri-implant defects are supracrestal. And in interproximal walls, these defects are intraosseous defects. This could be related to the presence of teeth in the interproximal walls, and sometimes it's more frequent that implants suffer in the buccal wall due to malposition or because the resorption that occurs after destruction of a teeth. So for planning in the treatment, the surgical treatment of peri-implantitis, we base it on the defects. And in cases of favorable defects with 4 walls, regenerative approaches will be used. But when we have less walls because the defects are more advanced, we start to reduce the success of the surgeries, and we use another type of approach like resective approach. There's an intermediate approach called combined surgery that includes regeneration of that defects that could be regenerated and the use of resective techniques like implantoplasty in walls that cannot be regenerative. We do that kind of surgeries in cases of 3 walls defect, but we only have 2 or 1 wall defect, we only can do a resective surgery. The objectives of surgical treatment are 3. I thought there are 3. First of all is to stop or control the infection. For that, it's important to eliminate the bacterial biofilm and achieve the complete decontamination of affected surface implant. And second objective is to maintain or recover the bone supporting the implant. And finally, the last is not to affect the aesthetics of the restoration or the aesthetics of the smile. There are such as prognostic factors regarding this type of surgeries that could affect the success of the surgery. First of all is the early diagnosis. Cases with small defects, initial defects, have better success than cases with advanced defects. In these cases, it's more promote or more easy to do regenerative techniques that have better results than in cases more advanced. Also, operator experience could influence the results of the surgery due to the difficulties of using some materials as barrier membranes, for instance. And finally, the success of the treatment depends on the patient, because that patient that don't have a control of his risk factors, such as smoking or history of periodontitis, will not achieve the better results after that surgery. First of all, I will present a case on 1 cases regarding to resective surgery. Resective surgery was described, peri-implant resective surgery was described basis on periodontal resective surgery. There are a lot of techniques, but they not have any technique superior to others. In our case, we used to do, as we can, resective surgery with osseous surgery and with implantoplasty. I present that case is a patient treated in the unit of maintained implants in the University of Barcelona, and one of our students treated, and as you can see that image from the revaluation after non-surgical treatment. That patient presented proving depth around 6 millimeters. And as you see in the photograph, they have a lot of plaque accumulation. All implants suffer peri-implantitis. Also, implant in position 24 was spline. We did 2 surgeries in 2 visits, and now I will present the left side. The first step is the incision making. In this case, we decide to do incisions similar to a ring in the palatal region. The objective of this velvet incision was to do the excision of soft tissue to reduce proving and to achieve an apical reposition of soft tissue after the surgery. This kind of incision could not be done usually in buccal area due to the amount of keratinized tissue is more limited. In this case, we decide only to reduce the tissue in the palatal area, and that's the portion of soft tissue that was removed. That is the aspect of the defects after the elimination of granulation and inflammatory tissue. As you can see in the image, it were supracrestal defects with less intravoni defects in one of the implants. After that, we do all the removal of the soft tissue, the granulation tissue with curettes. We can use titanium or stainless curettes and with ultrasound. There are different methods for surface decontamination. Only titanium bracelets seem to have highest levels of evidence of superior to other methods. And in this case, regarding the last evidence-based guidelines, implantoplasty does not have enough evidence to be recommended. It's controversial due to our team routinely performs implantoplasty in all our resective surgeries. Why will we do that? Because publication of our research, our colleagues, in an in vitro study, we tried to find what was the level or roughness of time after implantoplasty. And we found a very good results regarding the roughness using this protocol of drills. After that, we do a proofs for show the implant fracture after different cycles of hits. And we found that there were no difference between implants with implantoplasty and implants without implantoplasty. So implantoplasty don't have any effect on fracture in that implants. Also, I would like to do that in this case, in our study, we use external connection implants that have a very strong walls, and maybe that result could be different in cases of internal connection due to the walls are more thinner. In our case, we use that protocol. We use a decreased thickness of the drills, and we start with that tungsten carbide drill. We use the drill in only one direction to remove the threads of the implants. We always work with external irrigation to reduce the risk of warming the implant, and we always protect the flap to reduce the risk of emphysema, especially in lingual side. Then we continue with that rubber boards for polishing the threads, and we finish with this fine grit polish drill. So as I previously said, implantoplasty has a lot of possible complications. So a recent systematic review observed that the risk of warming does not exist if we use irrigation. Also, titanium particles that sometimes we are very worried about it, by the moment are not associated for more complication after implantoplasty. Mucosal coloration was less frequent, and implant fractures in these cases, in this systematic review, not appear in the first months. In our case, as I previously said, we saw the same point of fracture in implants with implantoplasty and without implantoplasty, and the frequency of fracture was the same. So I recommend to do this step, the bone remodeling, after the implantoplasty, due to during this step, we do the cleaning of the titanium particles that previously we have already spread around the implant. And then we perform a bone remodeling to achieve an apical position of the soft tissues after in the suture. So for the contamination of the implants during a surgery, we use a sterile saline solution. Why do you do that? Because no other method have demonstrated superior effects. It really that maybe antiseptics could be better in the first seconds or the first minutes, but an immediate bacterial contamination will occur. Finally, we perform an apical reposition sutures. Now I will speak about regenerative surgery. Regenerative surgery includes the use of xenografts, barrier membranes, and I will include in regenerative surgery also a combined surgery, where we use tips of regenerative surgery, and also we do implantoplasty in that walls that we cannot regenerate. So the regenerative surgery is indicated in containing defects, and the minimum depth of intravenously defects should be recommended around 3 millimeters. There's not evidence, so any approach was superior to others. But when we talk about regenerative surgery, there are some key points that could be important for the results, for the success of the surgery. First of all, was to achieve a correct coronary reposition flap and a correct wound closure. It's important the type of bone substitute that we use, if it's necessary or not to use a barrier membrane, or if some techniques for healing are better than others, but we don't know if an approach with submerged healing is better than a non-submerged healing. For instance, another key point is the use of connective tissue graft during the surgery or in another surgery in the further time. That key points are partially responsive in the evidence guidelines, evidence-based guidelines, and they say that the use of biomaterials is indicated, but there's no any biomaterial superior to others. And barrier membranes may be used or not because it does not appear to influence in the results of the treatment. And currently, it could not be recommend any type of healing or submerged or not submerged because the results are similar. I would like to present regenerative therapy with connective tissue graft in a second stage. This case was also did by a student of the University of Barcelona of our master's degree. In this case, we have a patient that suffered peri-implantitis in only one implant. That's the situation after non-surgical treatment, and in reevaluation, we can show that she suffers bleeding unproven. She has bleeding depth around 6 millimeters. And in the radiograph, we can see that there is an intraosseous favorable for regeneration defect. Also, in the clinical photograph, in the intraoral photography, we can see a soft tissue defect. When we elevate a flap, we found that after the soft tissue removal, so granulation tissue removal, we see that we observe an intravenously defect and a horizontal defect in the buccal area. So we decide to do a combined approach. In this case, we start with an implantoplasty in buccal area of the implant, and we did a submerged regenerative approach with a bovine xenograft and the use of a resorbable barrier membrane. This is the coronal reposition suture, and that's the healing 6 months after. In this case, we decide to do a submerged healing. Also, 6 months after, as you can see in that image, we provoke a recession after surgery on the anterior tooth. Also, the defect of soft tissue still was present, but 6 months after, we achieve a bone filling of the defect. Afterwards, we decide to do another surgery to increase the volume of soft tissues with a connective tissue graft. We use a tunnel approach, and that's the incisions. This is the connective tissue graft that was placed coronally and buccally. This is the technique of traction of the graft with an elevator suture. And the graft was completely submerged. After that, we place the transepithelial and the crown, and 14 months after, these are the results. The recession of the anterior tooth was covered, the thickness of the soft tissues was improved, and a stable bone filling was obtained. So, as I have already explained at the beginning, all patients must be included in peri-implant maintenance programs. After that treatments, if we don't include patients in that programs, they will suffer relapse. And as we know, at that moment, the peri-implantitis have no linear progressions, also have times of more quickly advanced, and patients should be monitored by a dentist. And in every visit, it's very important to do the proving of the implant to show signs of inflammation. The compliance of maintenance visits reduce the risk of disease onset in implants, in healthy implants, and reduce the recurrence after the surgical treatment or non-surgical treatment in cases of mucositis. During the visit of maintenance, the adjuvant treatment with antimicrobials is not necessary according to the recent practice guidelines based on evidence, and the use of antibiotics is unjustified. What should include that visits for maintenance of implants? First of all, we need to control the risk factors in cases of smokers and a history of periodontitis. It's important to analyze the superstructure to change screws is necessary, and after all, do a subgingival instrumentation with curettes, with ultrasounds, with then using pulley cups, eye polish, laser if you have, whatever. But the cleaning of the superstructure and the neck of the implant is very important. After all, our patients should be motivated, and that's our point of insisting his or her at home oral hygiene. So oral hygiene instructions should be done in every visit, and it's very important to agree on next maintenance visit with the patient to don't lose that patient and have a follow-up of all patients that have our implants and another implant for other clinics. So does this treatment works? So unfortunately, I don't have good answer for that because the evidence of treatment success is low. The numbers are very well. The survival is low according to the best of the years. And all studies agree that treatment success and implant survival depends on the initial bone loss. So more favorable results will achieve in cases of initial defects. So for conclusions, in conclusion from this talk, only reliable tool for periimplantitis treatment is prevention. For this, it's essential to control the risk factors prior to place an implant, do a meticulous surgical planning, include patients in peri-implant maintenance programs, and when there are peri-implant disease, it's essential to the early diagnosis. I recommend to do a proving in each visit in patients that have implants. And if we found signs of inflammation, also a bleeding or bruising, a periapical radiography should be done to confirm the bone loss. And the treatment should be immediate. So let's not be ostriches. Let's face them the problem. And in cases of mucositis, I recommend to do non-surgical treatment. And in cases with peri-implantitis, first step is a non-surgical treatment to improve soft tissues conditions and reduce the inflammation, and then do a surgical treatment based on peri-implant defect. And finally, all patients with healthy implants and patients with mucositis and peri-implantitis should be included in peri-implant maintenance programs. So that's all. Thank you very much for your attention. And if you have any questions, I am happy to answer.
Thank you very much, Marta, for such an interesting lecture about peri-implantitis. As I've been telling you through the chat, please, if you have any question, just let us know. There is already one question. I will transmit it to you, Marta, and maybe our manager in India is also having some questions because he's also expert in dentistry. So let me read the first question. Is from Dr. Ankit Sirodaria. How do you see the role of laser for intermediate cases of peri-implantitis?
Well, I thought that it's a very interesting question due to publication related to laser in peri-implantitis has promoting results. But in clinical guidelines and in consensus documents, not always recommend laser because they're not found that its results are better than other methods like cures, for instance. But if you have a laser, you have the option to use a laser. It's a great decontamination method because it's a chemical and mechanical decontamination method. So, and regarding the next question is about if laser causes any bone resorption.
Bone resorption,
okay.
Yes.
Well, if the parameters are correct, laser is a perfect decontamination method. So are the parameters of the laser, what kind of laser that you're using, should be well established, and I recommend you to use it. I hope I have answered to your question.
Of course. Okay, there is another question from Dr. Baiba. How smoking affects to osteointegration?
Okay, smoke affects all process in the body, but in cases of osteointegration, there are some publications that say that there are more risks of failure or early failure of the implant not integrated. And once the integration was stabilized and affecting to peri-implantitis, today is not a more high evident risk factor, but these are important risk factor for the success of the implants. So if you can, I recommend you that all patients that are smokers, our role is to advise that it could be a risk factor for the failure of the patient, recommend patient to stop smoking prior to implant placement is possible, but if the patient don't stop to smoking habit, I recommend you to control more that patients and include it in peri-implant maintenance programs with visits more frequent than another patient that didn't smoke, that doesn't smoke. Because they will suffer more complications than non-smoker.
There is another question from Dr. Azar Siddiqui. What if the implant comes out due to the periimplantitis? How to proceed the next treatment?
Next treatment. Okay. Well, that's a very good question, because sometimes we have a very big defects after periimplantitis. Our case is very advanced, and we need to do and be able to do regeneration techniques, difficult regeneration techniques as vertical regenerations. And prior to that, it's important to know our patient. What's the reason because that implant has already failed? It's because he's a smoker, he suffered a periimplantitis that we have not already stopped. And then for the next implant that we will place, also I insist on that patient should be included in maintenance programs, because we need to check that patient, because one patient have already lost one implant will lose another implants because he suffers, he has risk factors that we know or maybe we don't know.
Another question from Rohit Singh. What is prevalence of periimplantitis in percentage?
Well, I refer to Lee systematic review in year 2018, I thought, and it's around 18% of our patients. When we see the prevalence of patients or implants, the prevalence of patients used to be higher, because one patient can, only with one patient will have one implant with periimplantitis is a patient with periimplantitis, but can have implants without disease. So around, I like to say around 1 of 4 patients with implants could suffer a peri-implant disease, because only 20% have periimplantitis. I thought it's a very high number, but about 50% of implants suffer a mucositis. And if we don't do nothing, a mucositis will progress to a periimplantitis. It's the precursor of a periimplantitis. But these prevalence numbers change in studies, because there are another factor that could be influencing, that is the sample. We need, if we are working in a university samples, we need to know that they are different from dental practice samples. In the dental clinic, maybe the numbers will be worse, because a lot of patients didn't came to the dentist after the placement of the implant.
Okay, another question from Dr. Swapnil Sagar. What are the most effective early intervention strategies to prevent it from progressing?
For me, I enroll in peri-implant maintenance programs to control pre-treatment is control the risk factors. History of periodontitis, smoke habit, and oral hygiene control is necessary periodontal treatment.
Okay, from Dr. Ankit Sirodaria, again, another question. As we do implantoplasty, do you recommend implant design with coronal smooth surface that may reduce chances of periimplantitis? Yes,
that's very interesting, because things are changing, and we are looking for less ruggedness surface, because the addition of the biofilm will be less. And when we do an implantoplasty, our objective was that, to reduce the addition of the bacterial biofilm and to achieve a better capacity for cleaning of the patient, for oral hygiene. So these designs are very interesting. Yeah, I agree.
Okay, if we place next implant of higher diameter and there is less torquing, how much time it will need for next osseointegration?
Well, every case is different, but in these cases, when we lost an implant, not for an early failure, because when it's an early failure, I refer to no integration of the implant. When we lost an implant due to a peri-implantitis, it's frequent that the defect will be more higher than the defect for not integration. And we used to, if it's necessary, do a first closure 1 month after or 2 months after, do a preservation or a regeneration. And after the months, 6-9 months, if necessary, to replace the implant. In some cases, every case is different, but when we have big defects, we cannot place a new implant in the correct position that we like. And regeneration techniques are needed. And our knowledge of regeneration is very important after a peri-implant failure.
Okay, what are the chances of peri-implantitis in wrong prosthetic design?
Prosthetic design is very important. Well, in the last, I will start with the evidence. In the last clinical guidelines, prosthetic design or not access to oral hygiene in implants is a risk factor with a moderate or low evidence. But there are some publications, and our clinical perception is that wrong prosthetic design is a risk factor due to the accumulation of plaque, and a patient that can clean his implant and his implant reconstruction will suffer inflammation, sure. So I thought that it's more important if you do the surgery and after you design the prosthesis, you will know why you should do a cleachable prosthesis. But if you only do the surgery and you have a colleagues that do the prosthesis, it's important to talk and explain them that the prosthesis should provide access for hygiene, for pass of an interproximal brush, for instance. If your colleagues doesn't understand you or can't do that, if you do the maintenance programs, you include patients in that programs and do the maintenance visits, during maintenance visits, you can modify the contour of the prosthesis, because recent publications are seeing that if we change that, we improve the health of the implant.
Okay, maybe you can read it from Raj Kumar Bansal. After implantoplasty, where should be the crown margin as it increases the cantilever on implants, and where soft tissue is not capable of hiding the portion of implantoplasty? Sorry, because it's a too technical question for me.
Okay, I understand it. I thought I understand that. Well, implantoplasty is indicated in cases where the aesthetic is not compromised. Because if we do an implantoplasty in anterior implant, the risk of recession is very high, and patients should understand that. In that cases, maybe there are other techniques less compromised, such augmented soft tissue grafts, or techniques without resective approaches, because the risk of recession is very high.
Okay. What are the regeneration techniques of bone defect after implant failure, and where to learn them?
Well, today I thought that I am a teacher in the university on a master's degree. And when I was a student, we do regenerative techniques, basic, regenerative techniques. But today we need more effective regenerative techniques. We need to achieve vertical regenerations to be able to change the situation after one peri-implantitis. And I don't know, if you send me one email, maybe I can recommend you some courses. But it's important to, if we place implants, we need to be capable, we be able to treat the complications of the implants. And peri-implantitis is a complication, but a failure of an implant after a peri-implantitis with a big defect is a very important complication. And sometimes, and if we can do that, we should to refer to the patient to a specialist in regeneration in your country, for instance.
Okay. Any experience of such smooth surface colored implants, as I have faced less soft tissue stability using such design implants? Soft tissue be stable over same? I don't know.
Well, my experience, I have experience with different systems. Well, my recommend more than, yeah, that surface have less addition for the biofilm, but maybe the position of the implant is too important, because in bone level implants, if the implants is 1-2 millimeters deeper that we will place it, maybe we will not have these changes, remodelation, and we don't have this first the issues that starts the peri-implantitis. And I can't recommend you any system or not, but I thought that changes in surface in the future will be important, and all implantology with based on changes in surface will be based.
Okay. What is the major cause of peri-implantitis? Occlusion or prosthetic or implant design?
Well, the cause of peri-implantitis are bacteria. Is an inflammatory response to a bacterial biofilm. There are such factors that could affect the adhesion of the biofilm and can create changes in the bone. But I thought that prosthetic design, a worse prosthetic design, would be related to not access to hygiene and overload. Well, was described prior to a risk factor, but in recent publication, it isn't that important that we thought previously. Bacterial are the problem, and the hygiene of the patient is the first step that we should treat and change.
Okay, there is a request of your email, so let me tell you that I will discuss with Dr. Garcia, and then when we send you the link to to download the video, we'll see.
Yeah, that's in the slide, but I can write it in the chat. Okay.
Okay. Thank you very much, Marta. So how much deep implant should be placed below bone crest? If placed 3 millimeters below, that chances of peri-implantitis is less?
Well, there's not a number, but the clinical implication of have enough thickness of bone surrounding the implant is important. Every case is different, but not thinner walls. Please let enough thick, or if you don't have it, do regeneration techniques, because the implant should be involved in walls of bone about 2 millimeters or more. Okay.
There is another question regarding a patient that brushes hardly. If a patient brushes hardly, can an implant loses its osseointegration?
No. I believe no. I don't know if any cases have what's happened, but no. For the business refers to cleaning, to dental business. No.
Okay, you already have the email from Dr. Marta García. It's her direct.
It's my university. Yeah, my university email. But you can send me any question there.
Okay, Alex or Lawrence has uploaded an image of X-ray image. There is a case, but please, I would not go too much in details, because we could, if everybody publishes the cases, would lose a lot, would spend a lot of time. So I don't know if you can see the case.
Yeah, I see the radiograph, and Does the patient have pain and come to the clinic? Just check with gums have swelling, need to take no. Maybe if you have with that radiograph, you don't have bone loss. I thought that could be a remodeling because now bone loss is equal or greater to 3 millimeters. First of all, you need to treat the suppuration, the inflammation of soft tissues, and also non-surgical treatment with curettes, ultrasounds, and antiseptics, for instance, irrigation with chlorhexidine. And after 6 weeks or 2 weeks of chlorhexidine at home too, and 6 weeks after, see the patient again, and let's prove the soft tissues, because maybe it could be related to inflammation only. The soft tissues could be only a mucositis, but if we don't have the proving, we don't know if in the buccal plate you have a diasense. Only with the radiograph have information regarding mesial and distal area. So maybe it could be that. I thought it's very important to know the diagnosis tools. No? The proving is more important. More important. Every visit you do proving of the implant. If you show bleeding, you have a sign or something's happened. So with bleeding, a radiograph should be done, and with presence of bleeding and changes in the bone, you have a peri-implantitis. But if you don't have changes in the bone but have bleeding, you have a problem also. You have a mucositis. So do the treatment for a mucositis. Mucositis is non-surgical treatment, and do a reevaluation after 6 weeks. Okay?
Okay, I don't know if there are more questions. You had a lot of questions, Marta. That's a good sign.
Yeah, I thought it's an interesting topic, but sometimes we don't have answer to everything because we have a big problem with peri-implantitis. Big problem.
It's a very complex
yes.
disease, very multifactorial. So I understand. I don't know if there is any other question.
Dr. Marta, can you hear
yes,
me?
Andrendra, go.
Yeah.
Please.
Yeah. So can you tell me something about, like, is there any role of PRF in case of peri-implantitis? Is it effective?
It's effect. Can you repeat this? I hear you, but I hear you very
low. You're
low.
It's PRF. I'm talking about PRF, platelet-rich fibrin.
Okay. For treatment of peri-implantitis, there are some publications. So the results are not better than another methods, but also improves the healing of soft tissues. It's very interesting for adjunctive for added that treatment to surgical treatment for improve the healing and improve the timing of healing also. If you do a resective surgery, for instance, and use it about 4 weeks, you will have a final healing complete. For that point, for that case point, is interesting. But this doesn't improve the bone loss only. This a complement of another treatment.
And can you tell something about, like, what are the systematic conditions, like if the patient is like any systematic, like high blood pressure or maybe diabetes mellitus, how does it affect, and what are the precautions a dentist should check in that type of systematic disease in placing the implants?
Systematic disease like diabetes, for instance, do you refer?
Like diabetes or with high BP, like there's less chance of peri-implantitis.
Okay.
In that patient, what is the precautionary method?
Well, the control of the risk factors include the control of systematic disease. Diabetes have a moderate risk factor for onset of peri-implant disease. So should be controlled prior to implant placement. And as we know, it's a chronic disease, so should be controlled during all whole life of the patient. So can affect the healing after surgeries, and can affect the aggressivity or the capacity of bacteria to damage, and their immunological response will be worse in a diabetic patient than in a healthy patient. There are another systematic diseases, rheumatic diseases, that already are being studied as a risk factor for more bone loss in implants than healthy patients. So it should be controlled in that phase, no, in phase of pre-treatment.
Okay, and can you guide something about, suppose what could be a better design in the terms of implants placement, because we got micro threads, macro threads, the platform switching concept. So can you elaborate something about which design is more favorable to have less chances of peri-implantated in a hole, like whether the macro threads or the surface threads or the micro threads, or what are the conditions, like internal connection is better, external connection is better, something like that. Like, so if they place in that type of implants, could be useful in preventing the peri-implantitis. So can you guide something about that?
Yeah, I am agree with you, because I thought that the changes in the connections, platform switching, reduce the onset of remodeling of bone, and there are less risk of onset of an inflammatory response due to bacteria. So if we can change that, if we can improve our first remodeling and achieve as zero remodeling in the first step, that implant will be during more time healthy. And if an implant disease onset started, could be related to other factors, like the patient didn't cleaning or plaque accumulation. But if we have a connection that induces a bone resorption about 2 millimeters, this implant will suffer and will be more risky to suffer, to onset this peri-implant disease. So that changes that are have already occurred in implantology could reduce the prevalence of peri-implant disease. We need to work a lot in that, but maybe sometimes there are other factors such prosthesis design. Everything should be done correctly. But I am a lover of platform switching implants because of this.
There is another question in the chat, and we should be going to the end. In case of chemotherapy, what will be the protocol for implants placement?
Well, as for the medics, because it changes year by year, and according to the drugs of the treatments that the patient are using, will be changed. First, ask to the specialist, and then always work in a more possible healthy situation. If you have periodontitis, treat prior periodontitis. If you have another disease, treat it prior to place implants, and have the consent, and the decision making should be done by the specialist in oncologic treatment.
Okay, I don't know if there are more questions yet. Amrendra, any last question or no?
Like one more issue is there, like at the time of the implant placement, what do you recommend? Like it should be placed beneath around 1 to 1.5 mm beneath the bone surface, or at the bone level, or what is the better method to put it down to prevent it for the future, maybe peri-implantitis? What do you recommend?
Referring to the steps of placement?
Yeah. Suppose it has to be placed at the bone level, or you advise to place the implant at around 1 to 1.5 mm beneath the bone surface to prevent it for, what is your recommendations, like prevent it from maybe peri-implantitis?
Well, in bone level implants, well, I have already talked about that, because I thought I recommend to place implant a little deeper to obtain a good thickness of bone surrounding all implant. And in prosthesis design, that's important because if you have enough length for the design of the prosthesis, you can use transepithelial abutments, and with transepithelial abutment, results of inflammation in soft tissues are better than without using of that abutment. So if you could do that with a bone level implant, I prefer to place it deep 1 or 2 millimeters from the bone level. I don't know if I answer your question.
Okay, so if there is no more any other question, so we are going to finish today. It's been a long webinar today with a lot of questions, very interesting. That shows that it's a topic that matters to everyone. So thank you, Marta. Thank you, Dr. Garcia, for your very interesting presentation, clear presentation. And we have to count on you for the future, of course, as we already do. And thank you to all the attendants today for being here. As always say, you will receive an email in the coming days with a direct link to download this presentation. You will be able to see it again. And if you have any question, you have in the chat the email of Dr. Garcia, or you can send an email to GMI collaborators, and we will try to answer everything. So thank you all, and see you in the next meeting in dentistry, GMI. Thank you, Marta. Bye-bye.
Thank you very much. Bye.